Hey.
How's the event going so far?
Oh, wow. It is going amazing.
How
There
about
is a
intense?
lot of activity, very, very intense competition going on right now.
Yep.
So I worry about your ability to continue with on the in first place for this year. Are you gonna lose
Uh-oh.
your place on the plaque?
Uh-oh. We got to do something. We got to step it up.
Yeah. Cedar Sinai is definitely coming at you.
Yeah. No, I
And then,
see
and then
Cedars.
I And then I found out this morning that Harvard is recruiting some more, so they had another person join today.
Good. Good. The more the merrier.
All right.
So I'm not as familiar with WebEx as I am, Teams and
Mm-hmm. It should be exactly the
okay.
same-ish. The same, if you look across the bottom, they're pretty similar.
Sounds good.
Um,
Are you able to see me or no?
yes, I can see you. You and I are the only ones who have our camera on.
Okay.
At this moment, one thing I am looking for is the chat.
Yeah, that's what I was looking at too. Is there a chat or is there
Now Jamie set the meeting up. I did not. So there should be.
I'll let you find that then.
Mm-hmm.
See it on the bottom right.
Oh yeah, actually, yeah. In the bottom right, all the way at the bottom, there's a chat.
Oh, there I saw
Three
something.
squares with a plus sign and then a
Yes.
little person. All right.
And I think if somebody types something like Jamie just typed in hello and
Yes.
came in.
Yeah, she said hi.
Oh, there we go. Now I opened it. Okay, cool.
There we go. All right.
Smiley faces. We're good to go.
That's right.
Oh, so you had an hour and a half for this. I think about 45 minutes tops. Is that okay?
Mm.
Okay.
We've never done one before. So this
I
is
know. This is
IFFGD.
the right.
This is our inaugural program
Excellent.
of Journal Club. Oh, ooh, we're getting a lot of people now. I can't see the numbers on I'm sure I could if I knew where to look, but so I don't know. Um, yeah, we didn't want it just turning off because
Okay.
WebEx is a little bit different that way. We were afraid that it might just like shut you down in the middle of a conversation. So we um we booked it for extra time. But yeah, I figured 45 minutes to an hour is probably going um to get us taken care of for sure. Oh, there's the participants list.
Yeah, and in the top,
Oh, I see.
where it says there's numbers.
32 so far. Right. This is an easier way for me to let people in anyway. So we'll give about another minute, and then we're going to go ahead and get started. Right. All right, things have slowed down. I'm going to go ahead and get started, everyone. Welcome to the 2024 IFFGD Digestive Health and Wellness event. This is our very first journal club. First of all, I want to thank you all for participating in this year's wellness event, which of course is used by IFFGD to fund a research program. This research programs help to benefit junior academicians in the field of gastroenterology to enhance their careers and, of course, move that needle forward for all of us patients to ensure a better tomorrow for us all. So we appreciate your participation in the event as a whole. And most of all, I really, really want to thank you for being here today to join with us in our first journal club. And I'm really, really grateful to Amol Sharma, who's a longtime friend of IFFGD and myself personally. He is one of the leaders of the junior academician program here at IFFGD, and he agreed to do this first session for us. He's no stranger to y'all, I'm sure, but in case you don't know Amol, he's an associate professor at Augusta University Medical College in Augusta, Georgia, and he is a specialist in GI motility and disorders of brain-gut interaction, which we don't say, it's actually functional GI motility disorders. And he is actually going to do us the article today he chose is Meditation and Yoga for IBS, a randomized clinical trial. I really hope that you guys were able to download this from the link that Jamie provided to you in on the web, and we're able to read it ahead of time. He's going to do a presentation, and then we will have some discussion about this great article. Amol?
Thank you, Cecile. It's a pleasure to participate again from the first one 3 years ago to now 3 years into it, the Wellness and Walk event. It's been a lot of fun, and I hope everybody's enjoying it as much as I am. So in short, the My IBS study is the randomized clinical trial we chose to present. It's not a long read, but I think it's important to look at some of these non-pharmacological therapies for IBS patients. So hopefully this provides a little bit of perspective for people on the call and otherwise. So a little bit of background on irritable bowel syndrome or IBS. It's actually one of the most common reasons for medical consultation in outpatient GI clinic. It's associated with a significant reduction in patients' quality of life, and owing to that has a large negative economic impact on the healthcare system. And then it's well known that 40% of patients use some form of alternative therapy. And then with functional GI or disorders of gut-brain interaction, it's estimated that it's even more than 40%. The way we define irritable bowel syndrome is based on the Rome criteria. We're on the 4th version of Rome criteria that's been out for many decades. And with IBS, it's patients that have chronic greater than 6 months of symptoms of abdominal pain and disordered bowel habits. So that could be in the form of constipation, which we abbreviate as IBS-C, diarrhea as IBS-D, or both, which we also call mixed as IBS-M. If you guys, other than just using the black and white definition, I would encourage you guys to go to the personal stories and click irritable bowel syndrome, and you can find out patient stories of people with IBS to have more personalized experience and how these symptoms really impact their life. It's a very good collection of personal stories, and then you do get footprint points for the event. So highly encourage you guys to go to this site on the IFFGD page to learn personal stories as well as more information. So this is the study we picked up today. It was published in the Red Journal earlier this year. And it was a very timely article because it's been about 5+ years since any kind of RCT came out in terms of meditation and yoga for IBS, which is a very hot topic because there have been previous studies that have shown efficacy with meditation, mindfulness meditation, and then yoga more later for irritable bowel syndrome. But these interventions have been in person, and with the COVID pandemic, a lot of emphasis was placed on trying to get more virtual options of these treatments out to patients because the number of providers that could provide mindfulness, meditation, and yoga are limited. So I kind of broke this down into kind of how we would approach it in our journal clubs in the academic setting and at MCG. So just to describe the study design for those of you that are unfamiliar with this process, whenever you try and design a study, you need to take a couple things that are standardized into account. So this is a randomized, unblinded, 2-group controlled trial. So the patient selection is important to consider when you're looking at designing a study. And here we have adult patients only. Some previous studies with yoga and IBS have included adolescent patients, and it's been interesting that they've been able to follow and make the adjustments even in adolescence to improve their symptoms of IBS. It's important to have an adequate understanding of English. This study didn't provide the questionnaires in different languages such as Spanish, and just stuck with people that spoke and read English. They required a score of, excuse me, greater than 75 out of 500 on the IBS-SSS, the IBS severity scale, and that is considered to be mild IBS. So if you look at the blocks in the middle, it defines mild, moderate, and severe. So mild IBS has a score scale of 75 to 175, moderate is 76 to 300, and then severe being greater than 300 on this standardized and validated questionnaire. They required stable doses of IBS medications, so this couldn't have changed 8 weeks prior to the study as well as during the study for 8 weeks. So that's 16 weeks of patients not changing their medicines when they were enrolled or considering the study. And then continued treatments with no new medications added to patients' treatment regimens during the study period. So for 2 months, patients couldn't have added new treatments, and they would continue their treatments, whether it be hypnotherapy or other forms of alternative therapy. Diet needed to be continued during the study period. So if you look at the practical implications of that during the study, patients have to be very, very stable on what they're taking so that you can ensure that what you're studying, which would be yoga and virtually delivered yoga in this study, is the only variable among reason. The exclusion criteria were major physical impairments for people that couldn't practice yoga and the different asanas, so they had to be able to be relatively flexible. And then major cognitive, psychological, or psychiatric disorders. And they divide severe depression as a major psychiatric disorder with this PHQ-9, a validated survey with a score of greater than or equal to 20. So the study was a Canadian study. It recruited all across Canada. And the way they got their patients or participants was through a previous IBS survey, a previous cohort study that they had performed, GI clinics across mainly Calgary, social media, and self-referrals. The patients were randomized into a virtual 8-week yoga program or an advice-only program where they were given a bunch of resources to read up on, and so that was considered advice only. The duration of the study was 8 weeks, as we mentioned. So whenever you design a study, you want to design a study, particularly look at a primary outcome or endpoint. So the primary outcome on this study was a decrease of this IBS symptom severity scale, or IBS-SSS, of greater than or equal to 80 points. Okay, so if we look at how they determined how many patients they needed or the sample size of the study, they quoted as clinically meaningful difference of greater than or equal to 50 points on the IBS-SSS. A reduction of greater than 50 points would be clinically meaningful, and that's what other RCTs looking at yoga and IBS have used, but they wanted to go for a more aggressive, and I commend the authors and investigators for doing that, a more aggressive endpoint with a greater than 80-point reduction in this score as a significant change. The sample size was determined to meet an endpoint of a greater than 80-point change in the score of 25 per group, and that would give that mean difference of 80. So there's some statistical values here that I'm not going to cover in too much depth, but they needed an alpha significance level of 0.05. So these are p-values that you commonly see in studies of less than 0.05. So that means there's less than 5% chance, less than 5% of a chance that if you repeated the study, that this would just be due to chance. It's more likely due to the variable that you're studying, or in this case, yoga impacting IBS. So if you repeated the trial 100 times, 95 or more times, this result would occur, that there would be what they would hope that yoga would have a meaningful impact on IBS symptoms. With an 80% power, which is a moderate amount, and then what is of note is they found a standard deviation assumed to be 103.8. So this is a little bit problematic with this score here, the IBS-SSS, because you're looking for an 80-point difference, and the standard deviation of a score, so amount that the score varies from from IBS patient to IBS patient is quite large. It's 103, which is more than the 8-point difference. So that is a little bit of a problem and a trouble in terms of overcoming this study. They assumed that 30% of patients who enrolled would drop out, and therefore above and beyond the 25, they needed 8 more patients per group, or 33 total IBS patients per group to perform the study. Some other standard things that you see with a randomized trial is that they had a computer-generated randomization, an allocation on REDCap, which is a commonly used software for data entry and data analysis in RCTs, or randomized control trials. And then they blinded the principal investigator and the statistician. Now, an issue with these kinds of studies in yoga and randomized control trials is that the participant remains unblinded. So they know if they're getting yoga or they're getting the advice only, which we'll discuss further. So the trial is all focused on getting numbers to meet a primary endpoint, but oftentimes a lot of studies include secondary endpoints, and this isn't to find significance with these secondary endpoints, it's just to add additional information that can be gleaned when doing the study. So they looked at quality of life, anxiety, depression, perceived stress scale, and then because this was at the time of the COVID pandemic recently in 2021, a COVID-19 stress scale, fatigue, somatic symptoms or bodily symptoms through another validated questionnaire, and self-compassion, which is a validated short form questionnaire about self-compassion. Some other endpoints that were secondary that I thought were pretty interesting were the intention to practice yoga. And this is based on a theory of planned behavior. So it's more of a sociology kind of metric that assesses people's intent to actually do the yoga that they're signing up for or being randomized potentially to. And that has been shown to actually correlate with people practicing yoga and actually carrying out what they plan on doing. And then there are feasibility metrics that were also looked at, the attrition rate, so the percent of participants that completed the whole study from baseline to 8 weeks out, and the adherence, so people attending all about greater than or equal to 75% of the classes that they signed up for over 8 weeks, and then having less than a 30% attrition rate, so less than 30% of patients who didn't complete the entire study for 8 weeks and all the forms that were involved. So you can see that with the secondary endpoints and the primary endpoint, there's quite a bit of paperwork in these clinical trials. So that's for many functional GI disorders, is that all the studies do require quite a bit of paperwork burden for patients, but all that is in the interest of finding a treatment that's effective for their symptoms. So here it shows the flow of the study from enrollment onwards. So they found that 142 patients, through all their ways of trying to screen for patients, were eligible for the study. So they met those inclusion and exclusion criteria that we discussed earlier. Of those 142 patients, 63 were excluded. So that's a pretty high exclusion rate. They were excluded for not meeting the inclusion criteria, and then no longer being interested. 41 of 63 were no longer interested in the study. So the yoga intervention versus advice only didn't appeal to quite a bit of patients. And so therefore 79 were randomized into yoga, which were 38 in that arm, and then 41 into the advice only control arm. And then the ones of 38, 7 were actually allocated the intervention that they actually made it to that first class. And then 7 withdrew before they were made it. So they were just no-show. 7 no-showed, and then 7 didn't receive the intervention because they just dropped out. Whereas everybody kind of received the intervention on the advice only arm. And then with loss to follow-up after getting enrolled in the study, there was 1 that was lost to follow-up, whereas 5 were lost to follow-up on the advice only arm, and then 4 discontinued due to a variety of reasons. And so they were left with 27 to analyze on the yoga arm and 36 on the advice only arm. So not quite reaching the 33 that they wanted to in terms of analysis of people that were in the intention to treat analysis. So that means the per protocol analysis. So there's 2 types of analysis that you do on studies. The intention to treat would be the people that made it to the initial allocation of the study arm, the intervention arm, that get included in analysis, even if they finish or do not finish the study, and those per protocol that finish the entire study as they signed up to do so, and they didn't quite reach the 33 that they wanted to there. So here, I'm just highlighting the different things that we just went over in this slide. Every study that is a randomized control trial is include patient characteristic table, and this one is no different. Here you can see the demographics shouldn't be different between the yoga arm and the control arm, which is the case with respect to percent women and men. The age is about the same at 47 years of age. Most patients were white, especially in the yoga arm. And then the marital status, most of them were married. Similar percentages were married in the treatment arms, and the length of their IBS was about 11 and a half years across the board. With regards to the type of IBS, they had about 17 to 20% had constipation predominant. I would say that's different than my practice personally, because I have a lot more IBS-C than I do with the other types. Here they had more IBS-D and IBS-M than I do in my practice. In terms of patients on medicines, about 20% were on medicines. A larger number, 55% were on over-the-counter supplements. 55% or so were on restricted diets. And then 12 to 20% had tried cognitive behavioral therapy. 1% or so were on hypnotherapy. And then there was a 5 to 7% on relaxation therapy. And then 5 to 10% had tried stress management therapy. So all these alternative therapies, a lot of patients, at least in this Canadian cohort, were exposed to alternative therapies through CBT, hypnotherapy, relaxation therapy, and stress management. With regards to comorbidities, a lot of patients had a lot of other conditions. About 10% had inflammatory bowel disease, or IBD. So we see a lot of patients with an overlap of IBS in their IBD, and when their IBD and inflammation is controlled, they have symptoms of IBS that persist. And then there were a smattering of other diagnoses that occurred, most notably that a lot of patients had migraine and tension headaches. 30% or more had those kinds of headaches. And then if we look at prior exposure to yoga, so patients that had, they were currently practicing yoga, that was about 3 to 7%. With the ones that had practiced yoga regularly in the past but didn't currently practice yoga, that was about 20 to 30%. And then ones that had tried yogas in the past but didn't practice yoga, so people had given up on it, was about 55% across the board. And then only 10 to 15%, or 5 that had not tried yoga before. And then something to highlight here is 22 or 23% of patients would have missing data at baseline. So this kind of breaks down this is the study highlight page here. Then we'll go through more of the results in more nuance. So again, this is the randomized 2-group control trial, the MICE IBS study. They had 79 adults with IBS enrolled, 38 were in yoga, and 41 were advice only. The duration of the study was 8 weeks. The primary outcome was a decrease of greater than or equal to, that's a mistypo. It should be 80 points on the IBS-SSS. And then the highlight results with the primary outcome is that 37% had met that primary endpoint of 80-point reduction. And then that compared to 20% with advice only, and that did not meet statistical significance. So there was no difference with regards to the primary endpoint of yoga versus advice only over 8 weeks. So their conclusion here was virtual yoga for 8 weeks was not superior to advice only in IBS symptom reduction. So that is considered a negative study. So here you can see a little bit more color on the primary endpoint with the IBS-SSS. Their baseline symptoms were 255. So that's moderate disease severity with the IBS symptom score. And that decreased to 200. So it met about a 50-point reduction not quite the 80 that they were after. With the yoga arm, with the control arm, there was a baseline of 236 that went down to 213, or a 22-point reduction, also not meeting the 80-point reduction. And the difference between the two groups was about 32 points, and that was not a statistically significant difference between the two groups. Regards to other ones that did differ between yoga and advice only, the quality of life scores did differ, fatigue did differ, and perceived stress did differ. So those metrics did change when you compare yoga to advice only. And then looking at just responders, so they did a subgroup analysis. So you can do many subgroups analysis. The ones they chose is to look at responders amongst the yoga only group versus the control group. And they found that quality of life, fatigue, somatic symptoms, and COVID-19 stress differed in yoga significantly, where it did not in control. But in terms of the difference between the two groups of responders in yoga and control, only self-compassion differed. I found an interesting metric that they looked at was they looked at how many minutes, and they actually tabulated this in their surveys, did these participants do yoga. And they found responders, there was quite a longer amount of time spent doing yoga, which is about 1,200 minutes, compared to non-responders, which was a little bit less than 600 minutes. So they made a calculation that said practicing about 620 minutes more over 8 weeks, over 2 months, practicing about 10 hours, it was associated with 5 times more likely to be a responder, or symptom reduction of IBS symptoms. Obviously, this is a small number of patients, so take this result with a grain of salt, but it seems like people that get hooked onto yoga, that continue to do yoga on a regular basis, are more likely to have symptom reduction with their IBS. In terms of their secondary endpoints with intention to practice yoga, so remember, prior studies had suggested that an intention to do yoga would result in more actual performance of yoga. So the question they specifically asked was, I intend to do yoga daily for 30 to 40 minutes for the next 8 weeks. And it was a Likert score from 1 being very unlikely to 7 being very likely. So at baseline, both were about 6.5. So they were quite likely to practice yoga, both in the yoga group and the advice group. And at 8 weeks, the yoga group dropped down to middle of the road, about 4 on this 7-point Likert scale, whereas the advice only dropped down to 5.2. So slight drop here, more drastic drop in the yoga group. So, it goes to show that maybe the people doing yoga weren't quite as hooked on it, especially on that virtual platform, as it would cause an enthusiasm to continue to do yoga. With the feasibility of virtual yoga, the attrition rate was 29%, so just under that 30% that they were looking for. 79% of all participants attended the sessions. And then when they rated the quality of the program, 40% said it was excellent, 30% said it was good. 30% said it was great, and about 30% said it was good. And then about half said they would recommend it to others. So, the question is with this negative study, could they improve the quality of the virtual yoga program and maybe get a better result? The attrition rate was much less with the advice-only group. That's probably because it didn't require recurrent interventions. And the 8 weeks we discussed, their enthusiasm to do yoga. So when the authors discussed this study being a negative study, why was it a negative study? Why didn't they show that virtual yoga improved IBS symptoms? Now, with a lot of IBS studies, one thing that comes up is the high placebo rate. And this is with a lot of functional GI disorders, but in IBS, it's been, if you look at all studies in total, it's estimated to be 42%. So if you have 42% of doing nothing improving patient symptoms, then that's kind of hard to beat with any kind of intervention, whether it be yoga, whether it be mindful meditation, medicines, diet. But that placebo response decreases to less than 30% when studies go longer than 6 weeks. So this was an 8-week study. So potentially a study being a little bit longer, like 12 weeks and doing longer term follow-up, you may see a difference that separates yoga and the advice-only arm. Prior positive studies of in-person yoga intervention have used that 50-point, and we mentioned that 50-point IBS severity scale score as their reduction mark as a responder. So 80 might be too high, but then again, I think that this is a better endpoint to truly separate a patient that respond and don't respond. So I don't necessarily hold that against the investigators. The IBS cohort included mixed patients. They could have had constipation predominant, diarrhea predominant, or both. And then maybe there would be one of these cohorts that responded more to yoga than others that couldn't really be examined in this small sample size of patients. And then the study investigators mentioned that this study is not generalizable because the population, the Canadian cohort that they had was largely educated white women with high family income, and that may not translate to other populations of patients, such as mine in Augusta, Georgia, where we have more of a mixed ethnicity. So there are suggestions for future studies. Consider a longer study duration that we mentioned, greater than 8 weeks, and then studying the long-term effects of yoga on IBS. So after this intervention, look at it 6 months out and 12 months out. And if people continue to practice yoga, then maybe they may have continued benefit. Studying of a larger sample size to see the different subtypes, the effects on constipation, diarrhea, or mixed predominance separately might be helpful. And then considering a hybrid program. And we did this at our center when we tried to look at a biofeedback therapy for fecal incontinence. We actually gave them a home device to use, but we actually brought them in person for the initial visit to train them on how to use it. And maybe a similar in-person and then virtual, so in-person teaching of yoga techniques and then virtual program would improve that program efficacy, adherence, and patient outcomes. And even the satisfaction that we saw with the study, with the patients rating the yoga program might increase with that, and so will their engagement. Include objective measures of autonomic function to assess physiologic yoga response. So there may be people that go through the program and do yoga, but don't do deep enough breathing or other things that really cause an effect on their autonomic nervous system, increasing their parasympathetics and decreasing that stress and sympathetic response. So measuring these autonomic function measures may find the patients that actually did yoga effectively enough to have changes in these measures may be more apt to be responders. So, measures of this kind of thing would be helpful in terms of separating that out, and maybe people that didn't get there would need remediation. So they highlighted in-person yoga in prior studies, and there have been 8 prior studies in adolescents and adults with patients with IBS is effective for IBS. Virtually delivered yoga improves IBS symptoms, but may need to be tuned up a little bit more to show a difference versus a control group. The quality of life, fatigue, and perceived stress also improve with virtual yoga. And then virtual yoga is safe and feasible. So they showed these things in this study. And then I wanted to move over to just the practice of yoga in the study and a little bit more color with that. And I happen to be married to someone who is a yoga teacher and yoga practitioner. So she gave me a little bit of color on this. So a subtype of, they used Upa yoga, which is a subtype of Hatha yoga, which is developed by the Isha Foundation for Inner Sciences. And it involves these 5 different types of components. They would be directional movements with neck rotations, the Hatha yoga based namaskar or salutation, breathing practice or alternative nostril breathing, a meditation, a mantra meditation of the Om chanting, and then breath watching. So they did this online weekly for 60-minute sessions. So 60 minutes and they had on average 3 to 7 participants on a Teams meeting every week for 8 weeks. And they were asked to practice this in between weekly sessions every day at home. So there's a lot of variability in yoga practices, and this is just one subtype of yoga. A lot of them have origins in ancient Vedic scriptures, and it's thought to help practice not necessarily for IBS, but to attain unity with mind, body, and spirit. And it's been practiced for thousands of years. And at its peak, there were 14,000 different schools or disciplines of yoga, and each was catered to a different reason and a different type of a patient or subject or goal. And not all of them were medical. The most common techniques involved were body postures, which were called asanas, breathing, which is called pranayama, and meditation, which is called dhyana. So these are the main components of all the yoga techniques. And the common forms available today, especially in the United States and Canada, is Ashtanga, Bikram, Hatha, Iyengar, Kripalu, Shivananda, and Vinyasa. So these are all a little bit different in terms of their approach to different components when doing and balance of these components when performing. So in conclusion, there are many patients with IBS that prefer a non-pharmacologic option for IBS, and yoga definitely fits that. However, in terms of doing evidence-based medicine, it's really hard to show the efficacy of yoga in randomized controlled trials because just like this study, it's really hard to plan for a sham or placebo arm to blind participants. So even though that the principal investigator, the main investigator of this study, and the statistician were blinded, the participants weren't. So, you may have had a mixed exposure. So people were clearly interested in yoga. And even if they were randomized to the advice-only arm, there's probably a high chance that they practiced yoga or some form of yoga on their own. There's no way to wash that out in this study. So maybe, finding a difference in people that do yoga in terms of their autonomic function that was suggested in the previous slides, that might be a way to really tease out who's really practicing it the correct way to have an impact on their physiology and then hopefully their IBS symptoms. And then this study, although the IBS severity was moderate, they also probably included very severe IBS patients and then also very mild IBS patients. So, we've done this in our clinical trials with gastroparesis, where we have just excluded all mild patients and focused on moderate to severe patients. And I think that might be a strategy to help show a significant difference in patients that are getting an intervention like yoga. So these are my thoughts on the study. I think it was a very thought-provoking study. I think it's very useful with our patients to improve many modalities of treatment. And I think it warrants further study. But again, it's been more than 5 years since there's been an RCT in yoga in IBS. So it just goes to show that it takes a lot of time, effort, and coordination to do these kinds of studies, but it's encouraging to continue to pursue. With that, I'll take any questions.
All right, thank you, Amol. We do have a question that is in the chat. Chris actually put in the chat, given people with gastroparesis commonly have an overlap of IBS symptoms and are more likely to have slow transit constipation, what is your sense of whether this technique would be beneficial to patients with gastroparesis with or without IBS?
I tried to find that question while you were reading. So I think if I could summarize the question again, it's how would this translate to gastroparesis with patients having slow transit? Yoga and meditation, I don't think that there's any data in terms of it changing GI transit, whether it be stomach emptying or small bowel or colonic transit. So that's not known. This is more yoga and mindful meditation targeting the visceral hypersensitivity that comes with these disorders. That means that a hypersensitive gut, these patients having this disorder where even normal stimulation, like eating a bite of a sandwich that would not cause any symptoms, causing symptoms potentially, and kind of reducing that input of it reaching the brain and causing symptoms. So I think that's where it would have more benefit than necessarily the transit side of things.
Thank you, Amol. We have a lot of people that have called in, so I'm going to read these out loud so that the people that are on the phone can also hear the questions that are coming in. So we have another person calling in. Okay. So we have a question. It says, thank you for a great presentation, Dr. Sharma. I wonder, by making the primary endpoint more stringent than previous trials, the 80 points versus the 50 points, as you mentioned, and resulting in a negative study, are we missing out on something that could reasonably help patients? Given that they were already on several other treatments, would one expect that high of an improvement in the IBS-SSS?
Yeah, no, I agree. I think there are two things, right? So yoga for IBS is effective. There's been 8 RCTs that have shown that. They were trying in the COVID era to look at a virtual yoga intervention to see if it was effective as well for IBS, so that it could be offered to more patients that may be location constrained from getting to a yoga expert, so that it's more available. So, we've done a similar study. Again, I mentioned we did a home versus office for biofeedback therapy for fecal incontinence, and we made it a non-inferiority study. So I think that might be a good first step to revisit when going virtual versus an in-person kind of therapy, to make sure that it's just as efficacious as the in-person, and then maybe looking to take the next step and go for a more stringent endpoint. So yeah, I think trying to take those two steps in the same study was very ambitious. I commend them for doing it, but it may have also resulted in a negative study. But it shouldn't. I don't think the reader should take away from this study that yoga is not something that would improve IBS symptoms.
Thank you, Amol. We do have one more question. It says, thank you for this information. Do you ever refer IBS-C specific patients to pelvic floor physical therapy? If so, what have been the outcomes, and has this been studied?
Yeah, so there's quite a bit of overlap with IBS, with constipation patients having IBS-C, slow transit constipation, and then also dysenergic defecation, which is pelvic floor dysenergia. And those patients have benefited from biofeedback therapy. Everybody does a biofeedback therapy a little bit differently. We do an anorectal manometry in constipated patients to prove they have dysenergic defecation, and in multiple positions to make sure that it also exists in the seated position before putting a patient through a 6-week biofeedback program with manometry catheter in place to help guide their pelvic floor physical therapy or biofeedback therapy. A lot of places don't do that. There's been studies in the past that have shown an 85% improvement in constipation and reversal of dysenergia if you follow a similar program with 6 weeks of weekly treatments. But again, just like many other therapies, you need a willing patient in this, an enthusiastic patient. You need an expertise with a practitioner or a nurse to help go through biofeedback to ensure the patient success. And then you need patients to be able to travel to centers of expertise at this point, because it's not something that's available right now in an in-home form of treatment.
Thanks, Amol. I did want to, when I was reading the article, I have a question. So what is your response to the fact that they talked to the people about being in the study that utilizes yoga, and then they did a baseline score of intention to do yoga, and not everyone said that they intended to do it, that was in the arm to do it? I mean, what is that normal that would happen? That to me struck me as very odd, that they know that they're about to undergo 8 weeks of yoga therapy and they're not intending to do it.
Yeah, so I think that kind of makes it more real world, right? So they're having patients that aren't just the most enthusiastic patients to do yoga that would do it. Then again, it probably decreases the efficacy of the study arm, because these people aren't so enthusiastic to do it. So it may water down the results. But if you look at it, the intention to do yoga was similar on both arms. I think by asking that question to the control group or the advice only arm, that those people who are enthusiastic to do yoga may do yoga and it wasn't really collected. And so that might water down the results in terms of these people should be advice only and then refrain from instructed not to do yoga, right? So I think that by asking that question, you put it top of mind, and it kind of makes both. You don't have a pure yoga arm and a pure not yoga arm. So I think that's where it more affects it. Asking on the front end and just kind of cherry picking the ones that are really enthusiastic about doing yoga may not then be generalizable to a real world clinical practice. So.
Although it does speak to patient preference though, right? So if we gave people the option in the beginning, are you enthusiastic? Is this something you really want to try? And that shared decision making.
Yeah.
And the patient says, yes, I want to do this, then they're probably more likely to succeed at it than if a patient says, really, I'm not enthusiastic, but you know what, doctor, if you feel like I really need to, I'll do it. They're, that not having that enthusiasm may, that may actually be an interesting study in and of itself.
Yeah, and then enthusiasm at baseline is one thing, but then again, doing the correct practice of yoga to make those changes in the autonomic function that could be seen, in different measures that now are widely available. You can get, wristband watches and things like that that can measure your heart rate variability and things very easily to see who actually is most effective at, reversing any kind of sympathetic overdrive and things like that, to see that they're doing the deep breathing and asanas and all those things correctly to drive that change. And maybe once they get that result or have that effect, then they're more likely to do it, whether they're enthusiastic at the start or not.
Very true. All right, I'm not seeing any more questions in the chat. Do we have a question in the chat or someone? I actually don't see any raised hands either. Does anyone else have any questions for Amol, for Dr. Sharma today? This is a very interesting journal article, and I'm glad you chose it because it is something that patients do ask for. They ask for alternatives to pharmacological treatment sometimes, or something to do in conjunction with.
Yeah, so I think, the main thing is that yoga is effective. It's been shown in other studies, and it should continue to be in the armamentarium of treating patients with IBS. And we'd probably need a little bit more work to do in terms of making it virtual, but definitely something that has shown efficacy and can be used in conjunction with other treatments or on its own for mild or moderate cases.
Very true.
Cecile, this was awesome. This was great. I hope we kicked off the journal club pretty well, right?
I think so. Thank you so much, Amol, and thank you for. I think the number I saw was 47. That we had attend, which is a lot more than we thought would attend, not knowing because we've never done this before.
Right.
So everybody, make sure you get into the Charity Footprints app. You log this activity, which is right at the top of the activities. Drop down and get your 3,000 points to really boost you ahead. Just want to make a note that for those that are watching the leaderboards, Amol Sharma and his team, the MSG Lucky Charms, are still at the top of the academic board, but I know some of you guys are coming after him. And then, of course, Fathom is trying very hard to keep that #1 spot this year that they took last year, although Ardelyx is knocking on their door. So this is going to be an interesting week to see how those leaderboards turn out. We really appreciate everyone's enthusiasm in doing this. Y'all, please join us on Wednesday. On Wednesday, we're going to have another good friend to IFFGD. Kyle Stoller is going to be doing our second journal club, which is the 2 that we're doing for this wellness event. And he is doing amitriptyline at low dose and tritated for IBS as second-line treatment in a primary care setting. So this is, it's got a couple different layers to it, but it's a very, very good read. It was in the Lancet Journal. You can find that link in the email and on the website. But this too was also randomized, but this was double-blind, placebo-controlled phase 3 trial. So this was very interesting article. I enjoyed reading it. I'm really looking forward to hearing Kyle discuss it with us on Wednesday. So I hope everybody will be able to join us then. Thanks, guys.
All right. Thank you, Cecile.
All right. Thanks, Amol. Bye-bye.